Welcome to this explainer. Today, we're taking those incredibly dense pharmacology and infectious disease notes and transforming them into a high-yield, strategic battle plan for treating bacterial infections. Look, if you've ever felt completely overwhelmed by the sheer volume of antibiotic classes, generations, and side effect profiles, you are in exactly the right place. We're going to break down the mechanics of these clinical weapons, making this info intuitive, structured, and honestly, impossible to forget. Let's get into it.
Here's our strategic roadmap. We'll start with the antibiotic battle plan, move through breaking down bacterial walls, sabotaging protein synthesis, and targeting DNA and metabolism. Then, we'll close out with prophylaxis and stewardship, followed by a rapid-fire finale.
Section 1. The Antibiotic Battle Plan. Before we deploy our pharmacological weapons, we absolutely must establish the strategic metrics and rules of engagement.
Okay, so the most crucial point here is choosing between bacteriostatic and bactericidal agents, and this totally depends on your patient's immune status and the actual infection site. Bacteriostatic agents, they just pause bacterial growth. That means they rely entirely on the host's own defenses to step up and actually clear the infection. But what if those defenses are compromised? Say you have a patient with neutropenia or an infection in a highly protected site with limited immune access, like meningitis in the central nervous system or endocarditis on a heart valve. In those situations, bacteriostatic agents just won't cut it. In those high-stakes scenarios, you absolutely must use bactericidal agents to kill the bacteria directly.
Now, there are 3 vital efficacy patterns that dictate exactly how we dose these drugs for maximum impact. The minimum inhibitory concentration, or MIC, is our baseline metric. For concentration-dependent drugs, think aminoglycosides, we want a massive initial strike. Basically, the higher the peak concentration is above the MIC, the more killing power you get. But for time-dependent drugs, which includes literally all beta-lactams, peak height doesn't actually matter at all. Their efficacy tracks strictly with the amount of time the drug concentration remains above the MIC. And finally, we have the AUC to MIC ratio, the area under the curve. For drugs like fluoroquinolones and vancomycin, overall total drug exposure across the entire dosing interval is what actually predicts their killing power.
Section 2. Breaking down bacterial walls. This is our first line of attack, dismantling that bacterial cell wall using time-dependent bactericidal agents.
These weapons, your penicillins, cephalosporins, and carbapenems, work by fatally sabotaging the bacteria's structural integrity. How? Well, beta-lactams bind directly to transpeptidases, which you might know as penicillin-binding proteins. This blocks the vital cross-linking of peptidoglycan stem peptides, which triggers bacterial autolysins that basically cause the cell to self-destruct. And we're constantly innovating here to overcome resistance. A great example is our use of novel combinations like ceftazidime-avibactam. The avibactam acts as a beta-lactamase inhibitor that acts like a shield for the beta-lactam, effectively giving us crucial coverage against multi-drug-resistant gram-negatives. We're talking Pseudomonas and even some carbapenemase producers.
You absolutely must master these cephalosporin generation spectrum shifts, and definitely pay special attention to ceftazidime and ceftarlane as high-yield exceptions. Generally speaking, as you move from the first to the third generation, you lose gram-positive potency, but you gain massive gram-negative coverage. But look closely at the third generation. Ceftazidime is an absolute outlier. It's the only third-generation cephalosporin active against Pseudomonas, but, and this is a big but, it sacrifices all gram-positive activity to do so. Then jump down to the 5th generation with ceftarlane. This is your holy grail for resistant staph, because it is literally the only cephalosporin active against MRSA.
All right, time for a myth-busting clinical pearl. While up to 10% of patients report a penicillin allergy, over 90% of those patients can actually tolerate a penicillin or a cephalosporin. It's incredibly important to distinguish a true allergy from a simple intolerance, like an upset stomach, because unnecessarily avoiding beta-lactams forces us to use broader and often more toxic alternatives.
But what if you are facing a true, severe penicillin allergy? Well, aztreonam, our only monobactam, is your go-to alternative here. Why? Because it has absolutely zero cross-reactivity with penicillins. And keep in mind, the true anaphylaxis rate for beta-lactams is extraordinarily low. We're talking just 0.05%. Even later generation cephalosporins and carbapenems show very, very low cross-reactivity in penicillin-allergic patients.
Moving on to glycopeptides, vancomycin requires very precise therapeutic monitoring. Since its efficacy is AUC to MIC dependent, we target a trough of 15 to 20 micrograms per milliliter for serious MRSA infections, just to keep that ratio over 400. But be careful. Push that trough above 20 and your risk of reversible nephrotoxicity climbs sharply. Also, if your patient's face and neck flush red during the IV delivery, that's red man syndrome. It's a histamine release, not a true allergy. Just treat it with diphenhydramine and slow the infusion down. Oh, and an absolute must-know clinical pearl for meningitis? If you give dexamethasone to improve outcomes, it actually reduces vancomycin's penetration into the CSF. Because of this, you absolutely must add rifampin, which penetrates the blood-brain barrier perfectly fine regardless of the steroid.
Section 3. Sabotaging protein synthesis. Next up, we're examining the drugs that infiltrate the bacteria and sabotage their internal protein factories, the 30S and 50S ribosomal subunits.
So aminoglycosides, like gentamicin and amikacin, are the bactericidal exception among protein synthesis inhibitors. Most of the others are just bacteriostatic. But here's the catch. You must constantly weigh the risk of reversible kidney damage against potentially irreversible hearing loss. Because of their post-antibiotic effect, which means they keep killing even after drug levels fall below the MIC, we can often use extended interval, once-daily dosing. This maximizes that concentration-dependent peak while giving the kidneys a much-needed break to avoid toxicity.
Treat this next one as a high-alert intelligence brief. Tigecycline carries a massive FDA black box warning for monotherapy. A pooled analysis of 13 trials showed increased death and treatment failure when it was used alone. And crucially, despite its really broad coverage for complicated infections, it lacks any Pseudomonas activity whatsoever. So it's a powerful tool for sure, but one with severe limitations.
The primary strategic challenge with these ribosomal attackers isn't just their spectrum. It's carefully managing their dangerous drug interactions and toxicities. Take macrolides, for example. They cause QTc prolongation, and most of them strongly inhibit CYP3A4, which can spike the levels of co-administered drugs like statins and warfarin. The big exception here is azithromycin, which doesn't inhibit CYP4, though it does still carry those cardiac risks. Then there's linezolid. It is fantastic for MRSA and vancomycin-resistant enterococcus, or VRE, but it's a weak monoamine oxidase inhibitor, an MAOI. That means if you mix her with SSRI antidepressants, you risk triggering a fatal serotonin syndrome. And tetracyclines? You got to keep them away from pregnant patients and children under 8 due to fetal bone growth abnormalities.
Section 4. Targeting DNA and metabolism. Let's shift our focus to the drugs that completely disrupt the supply lines, specifically targeting DNA replication and folate synthesis.
Now, while fluoroquinolones like ciprofloxacin and levofloxacin offer really powerful concentration-dependent killing by trapping DNA gyrase and causing lethal double-strand breaks, their severe adverse effect profile means they have to be deployed with extreme caution. The FDA has strongly warned against using them for uncomplicated infections because of some scary risks: Achilles tendon rupture, especially in older folks or those on glucocorticoids, aortic aneurysms, CNS seizures, and even exacerbating myasthenia gravis.
We also have some highly specialized agents in this category. Metronidazole is our heavy hitter for anaerobic targets like Bacteroides, causing DNA damage through reactive intermediates. But you have to warn your patients, absolutely zero alcohol or they'll suffer a violent disulfiram-like reaction. Then we have rifampicins, like rifampin. They block mRNA elongation, but they're potent CYP inducers. That's the exact opposite of macrolides, meaning they will chew through co-administered drugs really fast. Plus, they almost always need to be used in combination therapy to prevent high-level resistance. And finally, daptomycin, which depolarizes the gram-positive membrane, requires strict monitoring of creatine phosphokinase or CPK levels because it can cause severe myopathy.
Section 5. Prophylaxis and antimicrobial stewardship. Look, to prevent our arsenal from becoming completely obsolete due to resistance, we absolutely have to adhere strictly to the rules of antimicrobial stewardship. When it comes to the exact surgical prophylaxis protocol, you give the drug, usually cefazolin, within 1 hour before the incision. That maximizes tissue concentration right as the skin is broken. But the absolute most critical point here is step 3, discontinue after incisional closure. I can't stress this enough. Extending antibiotics post-closure adds zero benefit for the patient. It only drives resistance and risks a C. diff infection. Our core defense against resistance involves moving swiftly from broad empirical therapy, which is when we're essentially guessing based on epidemiology, to narrow, directed therapy the second those culture and susceptibility results arrive. This de-escalation really reduces adverse effects. Hospitals also enforce prospective audits with feedback, they restrict costly or broad-spectrum drugs like carbapenems or daptomycin, and they aggressively convert patients from IV to highly bioavailable oral options like linezolid or fluoroquinolones to get them out of the hospital faster.
Section 6, Rapid Fire Finale. Let's finish strong with a quick review of the absolute highest yield exam numbers and clinical metrics from this explainer.
You're going to want to lock these vital statistics into your memory. When treating a UTI empirically, remember that roughly 25% of E. coli in the U.S. is resistant to trimethoprim sulfamethoxazole, or TMP-SMX. For fluoroquinolones, the AUC to MIC target is greater than 30 for S. pneumonia, but you need an exposure greater than 125 for gram-negatives. Looking for a simple cystitis treatment? Phosphomycin works as a single 3-gram oral dose that maintains high urine levels for up to 48 hours. And if you're prescribing tetracyclines, make sure to tell your patients to separate the dose from calcium, iron, or milk by at least 2 hours. Otherwise, the drugs simply won't absorb.
I want to leave you with this final critical thought as you step onto the clinical battlefield. Wield these powerful tools with precision and care. Understanding the mechanics, from concentration-dependent killing all the way to recognizing severe black box warnings, is literally the only way we stay ahead of pathogens. Because right now, stewardship and pharmacology aren't just textbook concepts, they are the front line of modern medicine, which leaves us with one final critical question. With bacterial resistance rising and antibiotic pipelines slowing down, are we truly optimizing our current arsenal, or are we simply borrowing time? Thanks for joining me on this explainer, and I'll catch you on the next one.